I'm Kimberly Gray. I'm a pharmacy technician with the primary care heart failure team in Greater Glasgow and Clyde. So my role is mainly based around medications issues, adherence, compliance, education. Of my referrals mostly all come from the heart failure nurses. I also support the pharmacists with their post-MI clinics, so going out and supporting a hybrid remote model so that they can see more patients. I can do observations and bloods at home, as well as compliance issues as well. So usually we'll get a referral through, I'll go and speak to the patient. It just usually starts off as a chat. I don't tend to dive straight into discussing their medications with them. I usually have an idea of roughly what's been going on from whoever's referred them to me, and then I'm trying to get to the bottom of why they're having that issue. And there's very simple things that we can do, such as changing the times of a medications, condensing medications. But sometimes there are a lot of issues that are more down to kind of social things, and they're a little bit harder to sort out. I do tend to work quite closely referring to other services if people need things like home care, which happens on occasion. I've referred people to GAMH as well, mental health support, because a lot of that can really impact on people's ability to take their medication. In general, I will often visit people multiple times. We'll do things like counting tablets, making sure that they're actually taking it. They might not understand what the medication's for, what the benefits of it are. And so I spend quite a lot of my time doing education with patients. Oftentimes patients will feel a bit better after that, but sometimes there are still problems that require kind of creative thinking to get around. I'll often do like depression and anxiety screen with patients if I think something kind of flags to me that their mood is a bit low. Sometimes cognitive screening. These are things that you don't necessarily pick up at one visit or one time chatting. There could be many reasons why someone isn't taking medication. So it's good to try and figure out what that is. The pharmacists I work with are excellent, and they've been really encouraging, and they're really great for when I'm stuck with something. So I've got my HNC and I do my CPD every year, which have obviously become increasingly heart failure related. But a lot of it has been things like shadowing my colleagues at the start and speaking with them, speaking with the heart failure nurses. We have a meeting every 2 weeks where we can bring any issues that we're having with patients. And even if I don't have any issues with my patients, it's actually really good to listen to the issues my colleagues are having. So if the pharmacists are having trouble and they're all discussing something, it's really educational for me because I'm learning. It's been a kind of ongoing process of education, and I don't think that'll probably stop. So it's not unattainable for other people to have that and develop that service. To me, it's about using your staff where they're best placed. And if you've got a pharmacist doing things that they could be better utilised doing something else, prescribing and having clinics, then there's always scope to utilise other staff like pharmacy technicians. And I am able to support my colleagues with their clinics and allow them to see more patients, and I can go out and do their observations and follow up on them. And the same with the nurses. I free up their time, which is incredibly valuable these days. We all work as part of the MDT, and nobody replaces anybody. We all have slightly different skills.